У нас есть еще один великолепный лектор в нашей короткой лекционной сессии, доктор Фархад Хафези. И он эксперт в кросслинкинге и этой технологии посвятил много своих научных исследований. И мы рады видеть его здесь, чтобы он представил нам свое видение данной технологии, которые можно использовать, как мы знаем, не только у пациентов с кератоконусом, но и с другими заболеваниями роговицы. Пожалуйста, please.
Thank you very much for the kind invitation, and I very much enjoyed seeing your institute this morning and taking a seat in the chair of the big Professor Fyodorov and taking a picture there. Probably like everybody has done who has visited this institute. I picked out 3 topics today that might be of interest for you. The first one is crosslinking beyond standard keratoconus cases. So what do you do in a cornea that is only 260 microns thick? The second is new indications like crosslinking for melting of the cornea, sterile melting, and also PAC crosslinking for infectious keratitis. So if we look at standard crosslinking, the idea was born in the late 1990s by Theo Seiler and Eberhard Spörl in Germany. And then Theo moved to Switzerland, and we formed a team together with Michael Brochen and Hans-Peter Iseli. And it was in Zurich that the initial crosslinking technology was built. This was back in 2002, 3, and 4. From there on, crosslinking has become a global standard of care. It has CE mark and FDA approval, and it's being used all over to stop progression of ectasia. But there still is a lot to do in thin corneas. It's easy to crosslink a cornea that has a thickness of 430, right? So if we look at thin corneas in particular, this famous thickness of 400 simply came from the initial calculations of Eberhard Spörl, a physicist, who said, okay, in the late 1990s we had LEDs with a maximal intensity of 3 milliwatts. If we use them for half an hour, then we should have a treatment depth of approximately 330 microns. And because Spörl thought, oh, many doctors will use the technique to the very limit, they added 70 microns of safety, and there you are at 400. And this is how this famous 400 micrometer delimitation came. We then published the demarcation line. Nowadays you can see it at the slit lamp, but of course much better also in the OCT. This is easy nowadays if you have an established protocol for thick corneas. But what do you do in a keratoconus that is way below 400 microns? We were confronted with this question back in 2004 and 5, and this is how we developed hypoosmolaric solution. So we swell the cornea. If the cornea is too thin, we apply special riboflavin, we use osmosis, we swell the cornea over 400. This is what you can see here in the initial paper. So you take away the epithelium, thickness goes down, you apply hypoosmolaric riboflavin, thickness goes up, and you treat. But this technique is not that trivial and simple because many factors can influence the thickness of the cornea. Things as simple as the eyelid speculum. If you leave the speculum in, evaporation may have you lose 100 microns within 20 minutes. So you start at 390 and 20 minutes later with hypoosmolaric you are at 290 because of the speculum. Or if you decide to give a drop every 5 seconds or every 30 seconds, you will end up in a different thickness. So many confounding factors which sometimes makes it hard to treat thin corneas. Over the next years, more protocols came up, clinical protocols came up. May I ask you, how many of you perform crosslinking? How many of you treat thin corneas? Okay. So other protocols came up. It was the swelling of the cornea, and one of the most known other protocols is contact lens assisted. So you put a contact lens on the thin cornea, and this way you increase thickness. This also has a drawback because then the first 200 microns you crosslink is contact lens, not stroma. But all these techniques, they have one thing in common. They address the thickness of the cornea. And if you look at the parameters that you can change in a cross-linking procedure, it's physical. You can change the thickness of the cornea, which we do. You can theoretically change the concentration of the riboflavin, or you change the intensity in every patient. We don't do this nowadays. We have one fixed intensity, right? But if we could switch the intensity, individualize the intensity for every single patient, then this would be a nice parameter to play with. And this is what we have been doing in the past 3 years now. We know today much more about riboflavin diffusion. We know that oxygen is essential. So we have more factors, and it helped us to develop a new nomogram, a new algorithm. So what we do today is, if you take the Dresden protocol, it gives you a fixed total energy of 5.4 joule. On the left side, a thick cornea, keratoconus, so you treat 330 microns and the endothelium is safe. And today, if you have a very thin cornea, you would have a problem. So what do? You swell the cornea, or you put a contact lens on it, you increase thickness, make it thicker. What we propose for the future is the following: adapt the fluence to every patient. So if a patient has a 400 micron cornea, that's easy. You use the Dresden protocol. If it is a 300 micron cornea, why can't we find a fluence that also treats 75% of the stroma and leaves the safety of 70 microns to the endothelium? Same for 250. All we need is the algorithm that allows us to do so. So in other words, not use this fluence, but a different fluence, less intensity, less minutes of irradiation. We have published the algorithm last year in the Journal of Refractive Surgery, and we have at the same time started a prospective monocentric trial. And so far we have 56 eyes of extremely thin corneas with a follow-up of 1 year. The thinnest was 245 microns at the time of treatment. The thickest, of course, just below 400. And the success rate so far is 85%, and none of the eyes had endothelial problems. And 85% in extremely thin corneas is quite a good success rate. 95 in Dresden protocols and thicker corneas. So we believe that this would be the way to crosslink in the future. And it also will simplify the protocol. You don't have to think about all these factors anymore. What you will do is you put in the speculum, do the abrasure, give hyperosmolaric riboflavin for 20 minutes, and then you measure. And the measurement tells you 320 microns, and you will have a nomogram. 320 microns is 3 milliwatts for, I say a number, 11 minutes 20. To have a demarcation line at 75%. And we have established this, and we are waiting to collect a little more than 60 eyes, and we will publish in the next months. It will also make the whole surgery easier, because those of you who do cross-linking know that there is so many different riboflavin solutions on the market. And all of them should modify thickness. That doesn't make sense. One solution, one approach, simplify. Of course, what we do not know is, can we really stabilize a 250 micron cornea on the long term, over 5 years or 10 years? This, the future will show. What we know, we can crosslink safely without harming the endothelium with the maximum effect. That's extremely thin corneas. The next topic would be sterile melting. And that's really interesting, because if you are confronted with such a case, like below, bilateral melting after a corneal procedure, then crosslinking might be a means to stop melting. Because crosslinking does not only increase biomechanics, it changes the conformation of the collagen molecules, and it increases resistance against collagenases. So it slows down digestion, and melting is excessive digestion. And the way we believe it works is everything in the cornea is in an equilibrium, is in a steady state. Your cornea produces collagen, and your cornea catalyzes collagen. And in a normal cornea, it's an equilibrium. In melting, there is more catalysis. And what does cross-linking do? It blocks catalysis. So the first paper came out already 18 years ago, in the year 2000. These were 5 eyes of sterile melting, not infectious, sterile melting, published in the Klinische Monatsblätter. And we had an interesting case. It's only a case report, but the proof of concept is so interesting. We had a Terrien's disease, a peripheral extreme thinning that we cross-linked. And 18 months later, the cornea at this point was 100 microns thicker. We stopped catalysis, so more synthesis, thicker cornea in the periphery. And there has been another publication with 5 eyes with a good outcome in Terrien that was published 2 or 3 months ago in cornea. So this might be an interesting new indication, very rare disease, but something we could do about peripheral melting. The third topic is infection. And that's the topic that I like most, because I believe that we can change the way ophthalmology deals with infection. Today we have cross-linking for keratoconus. It works nicely, and we only discuss details. How many minutes, which machine, which intensity, but we know it works. Cross-linking for infection may really change the way we treat a global problem. And the idea of infection came to our group. We published the first paper in 2008. We had the idea coming from another project that was born in Switzerland at the ETH Zurich, which is called solar disinfection. The ETH Zurich had a project together with the World Health Organization. How can you make poor water, poor drinking water, how can you get it to a better quality in countries with poor infrastructure? And so what they did is you take water, put it into a PET bottle, you add riboflavin, vitamin B2, you put it into the sun. And after 8 hours, no more bacteria survive, no fungi survive, no herpes simplex survives, no acanthamoeba cysts survive. Everything is killed. Vitamin B2 and UV light. And then we thought, but that's exactly what we are doing with cross-linking. Vitamin B2 and UV light. So we did a first pilot study to address corneal infection. And this is not a rare disease like keratoconus. This is one of the global problems if you look at it on a global level. The pilot was promising. We treated 5 eyes, and our ethical committee said you can only treat eyes that were unsuccessfully treated with antibiotics for 1 month. Then you might try cross-linking. All 5 eyes healed. The next 5 years, we went back into the laboratory, and we also went into veterinary ophthalmology, simply because our colleagues, the veterinarians, have a big problem with infection in cats, dogs, and horses. So it was a good way for us to study the mechanisms. So we started treating cats. Jens Mortensen in Sweden started treating horses. And we learned that even huge ulcers can heal without antibiotics, only by cross-linking. The same Jens Mortensen managed in Sweden to tell his ethical committee, I want to do a small prospective phase 1 study, only cross-linking. In humans, patient comes with an infection, I don't give antibiotics, I only cross-link and see them every day. He had 18 eyes, and in 16 eyes he did not need antibiotics. These were all bacterial infections, and that's amazing. So only light and vitamin B2. And then over the years, we learned more about the effects. So how can cross-linking treat keratoconus and infection? How does this work? It is because you have 1, 2, 3, 4 effects happening in every cross-linking, also in keratoconus. But for keratoconus, you only need these 2 effects. Stiffening, making it harder, and increased resistance against digestion. But the effect number 3 and 4 also happen. You simply don't need it in a keratoconus case, but you need them in infection. What happens in infection? Number 3 means the bacteria stop replicating. Number 4 is oxidative stress, just disrupts the bacteria and the fungi. And number 2 is very interesting because it increases the resistance against digestion. And this is something antibiotics cannot do. Antibiotics only kill. Cross-linking makes the tissue more resistant against the loss of tissue during infection. So probably the scar, the end result scar, will be smaller. Over the last 5 years, we worked on these 2 topics. If we want to use this on a global level, we need to make the procedure fast, simple, and inexpensive. Making it fast worked. We published the laboratory data 4 years ago. In the Petri dish, we can take Staph aureus, so amoxicillin-resistant Staph aureus, and kill it in 3 minutes at 30 milliwatts, 98% killing. So we don't need to wait half an hour, we can do it in 3 minutes. And then we needed clinical validation, and validation was done by Boris Kneiser's group from Israel. Boris is in the room. And this was the pilot study that we published earlier this year, 21 eyes, as an additional procedure to antibiotics. This was just a feasibility study. Can we cross-link so rapidly? Boris has also started a phase 2 study where he had one arm only antibiotics and the other arm antibiotics and cross-linking. This work is submitted now. And what is interesting here is, look at the time to healing. 12 days healing in antibiotics, and if you do an additional cross-linking, you drop the number of days. That's important. Less doctors visit, less costs, faster healing. This is one of the cases that will now be submitted. And finally, we have a multi-center controlled trial running since 2.5 years. We have 23 eyes now in ulcers smaller than 4 millimeters, and here we only do cross-linking or we only do antibiotics, completely separate. And so far, all the PAC cross-linking ulcers healed without medication, without additional antibiotics. They take a little longer, but they heal without antibiotics. What the future will bring here is we have to go up with the fluids. Everything you've seen so far were the cross-linking machines for keratoconus and the typical intensity, 5.4 joule. Now we are trying to go higher, to 7 joule, to 10 joule, to 15 joule. And what happens, this work from my group is being submitted. The blue is killing of bacteria with the Dresden protocol or accelerated but the same energy. And this is killing at 7.2 joule. And we know that the cornea can, nowadays, we know that the cornea can easily tolerate 7.2 joule. So in the next 3 or 4 years, we will try to find out what is the best maximal fluids. So this is accelerate. The other is simplify. Simplify means this is how I usually do cross-linking. It works very nicely, but it's too expensive. The nurses, the room, the sterile environment. Why do I take a septic patient into an aseptic operating theater to perform an antiseptic procedure? That does not make any sense. If I sterilize the surface, I should use this infrastructure because this is what every eye doctor has in Bangladesh, in every remote area of the world. If you are an eye doctor, you very probably have a slit lamp. So what we tried is building this technology for the slit lamp, and it should be available next year. And the idea is to, in the future, perform cross-linking for infection. And why not, under certain circumstances, also cross-linking for keratoconus in the sitting position? 5 to 10 minutes with modern protocols are feasible in young patients. Lastly, I was in China a few months ago, and I talked to a very, very skeptical corneal surgeon who told me, we don't need this, we have antibiotics. And in China, antibiotics are extremely cheap. Why do we need cross-linking? And here are the answers. Please don't look nationally, look globally. It's a global problem. In 20 years, you will not have antibiotics that work. The antimicrobial resistance is increasing so much that we believe by the year 2050, more people will die of a common infection than die by cancer and diabetes. This is why the WHO has given a big warning on antimicrobial resistance. So the Vigamox, the Floxal in 20 years will not work, and this is an old class of antibiotics. It's 40 years old. Vigamox is a molecule from 1980. Fifth redesign of a quinolone, but the quinolones were discovered 40 years ago. So we will lose antibiotic efficacy. If you have an alternative like crosslinking, this will help a great deal. The second is, if you have 20 years of experience in cornea, it's relatively easy to treat infection if it's bacterial. But if you only have 2 years of experience, you will get in trouble. Is this bacterial? Is it fungal? Is it mixed? Crosslinking kills both. It kills bacteria and fungi at the same time. The third is you increase the resistance to collagen. So probably the end scar will be smaller. And in the end, sorry for that, and in the end, the Chinese doctor told me, well, the antibiotics are so cheap. Yes, but in most areas of the world, it's not the antibiotics that are the financial problem. It's us. The doctors are too expensive to pay for 2 visits, 5 visits, and 10 visits if you have an infection. Thank you very much for your attention, and if you want to hear more about it, please join us in Zurich in a few weeks.
Спасибо большое. Если вопросы доктору Хафези? Похоже, есть вопрос. Пожалуйста, микрофон.
Скажите, пожалуйста, когда вы используете кросслинкинг в лечении кератитов, проводите ли вы некроктомию, удаляете ли вы некротические ткани?
When you do crosslinking for corneal ulcer, do you remove the debris from the surface, or you just do straightforward crosslinking through the necrotized tissue?
I remove the debris.
Да, ответ да. Сначала удаляются дебрис и некротизированная ткань, потом производится кросслинкинг.
But I don't remove the rest of the epithelium because the riboflavin will go down and to the side.
Я могу поправочку сделать на русском языке?
Пожалуйста.
Professor Hafezi, I just want to explain some about this question in Russian, if possible, okay? Девушка, вашему вопросу, доктор, извиняюсь. Прекрасно, договорились. Мы делаем 1 миллиметр вокруг ультеративного, так сказать, абсцесса, немножко расширяем и потом производим кросслинкинг. То есть тем самым не делать полностью деэпителизацию роговицы. Это нет смысла, потому что это локальное лечение. Поэтому делать только миллиметр вокруг абсцесса.
May I ask you a question?
Pleasure.
Because my English is not really very good, I'm sorry, probably I lost some details. When you do cross-linking for the infection, you already have the diagnosis of the kind of infection? That's first question. Second question, if you know that it's a bacterial infection and you're doing cross-linking, do you add antibiotics as well? Or if is it a fungal infection, do you add voriconazole?
The first question, we do not know the nature of the microorganism when we start cross-linking. And right now, under study conditions, we are very often confronted with ulcers where a swab or a scrape has been done immediately, and we know clinical reality, nothing grows. So we are in this gray zone where we do not know what's happening. What we do in the study, we only treat for study's sake, without antibiotics, without voriconazole, and we only treat culture-confirmed microbial keratitis. And in the arm we are using, it's only bacterial keratitis in the multicenter trial. So for the sake of the study, we really keep a clear divide If it's cross-linking, it's 0 antibiotics.
Sorry, I'm not speaking about the study. I'm speaking about for the audience. What can we suggest to this doctor? To use cross-linking straight or wait for the diagnosis first? Do they have to add antibiotics or just cross-linking? Do they have add antifungal or just cross-linking? That's the question. Because I treat infection, I feel so worried to let the old approach and move to cross-linking, because if I don't have any special rules, I can be in trouble, because the cross-linking that is effective, as you show, can change the pattern of the infection and can change all in my job to decide what I have to do. For example, an early DALC for untreatable infection.
You raise an important question. Please realize that we are standing with bug cross-linking where CXL was 15 years ago. So if you want a clear recommendation here, this is an off-label use if you do it in 2018. For the sake of a study, as a scientist, I must separate the effects. I believe that clinically, in 2, 3, or 4 years, we will of course do a combination. You will of course continue to use antibiotics, but cross-linking might accelerate the time to healing and might limit the extent of the scar. But it doesn't help us to do this in a combined procedure if we scientifically need to dissect the two effects. This is how we learn about how moving forward. If clinically you have a problem now in 2018, feel free to use it as a last resort on top of your current treatment approach.
Я так полагаю, что здесь завязалась дискуссия по поводу практического применения, и, по-видимому, будет правильно добавить то, что доктора, выйдя из этой сессии и придя к себе в клинику в понедельник на работу, по-видимому, не должны сразу бросаться и делать всем своим пациентам с язвами роговицы кросслинкинг и не использовать антибиотики, что было сделано доктором Хафези в рамках клинических исследований. И мы знаем, что клинические исследования, они отличаются, научные исследования, от клинической практики, которую мы должны применять в каждодневной жизни, тем, что там, скажем, специально выделяются, искусственно выделяются группы пациентов для того, чтобы четко определить научную значимость этого метода. Поэтому на сегодняшний день мы, наверное, должны подчеркнуть, что если вы все-таки решите применять кросслинкинг, то ни в коем случае нельзя отменять антибиотики, и эту процедуру, если вы ее будете делать, то только, ну, скажем, как, скажем, вспомогательную технологию, которая может дать вам дополнительный эффект в случае резистентных язв роговицы, но ни в коем случае не как замещающую технологию. Это на сегодняшний день, завтра будет по-другому, послезавтра, может быть, будут еще какие-то рекомендации, но я думаю, это надо подчеркнуть, чтобы не создавалось впечатление, что здесь прозвучала рекомендация убрать антибиотики и всех лечить кросслинкингом. Это будет неправильно. У вас, по-моему, был еще вопрос.
Да. Я хотела спросить, делаете ли вы контрольные замеры после удаления дебриса и некротизированной ткани и методом ОСТ, пахиметрии, и насколько уменьшается толщина роговицы после удаления некротизированных тканей? И как защищаете окружающую здоровую ткань роговицы в момент облучения?
So the question was, do you judge the depth of the necrectomy before and after that with OCT, and also how do you manage the collateral damage that may happen during cross-linking if the ulcer is, say, close to the limbal area, and theoretically there.
Maybe I will start with the last, the stem cells. We have shown in an IOVS paper that we cannot really harm the stem cells with the amount of UV light that is currently used, and even with twice the amount of total fluence irradiating the entire limbus. We cannot harm the stem cells, and in 18 years there was not a single case of stem cell failure after cross-linking. That's the first part.
Ну, сначала поговорим о безопасности. Там возникал у вас, я так понимаю, вопрос, не повреждаются клетки стволовые, лимба при этой технологии. И, как сказал доктор Хафези, таких случаев пока до сих пор не наблюдалось не только у него, но и вообще при применении кросслинкинга за 15-летнюю историю. Поэтому похоже, что мы не должны бояться облучать лимб в тех случаях, если язва находится близко к краю роговицы.
And the second question, thickness. In the studies, of course, we do OCT, yes. In clinics, if you have a small ulcer that is 150 microns, 200 microns deep, you will not harm the endothelium because the amount of energy that reaches the endothelium through the infected tissue is too small. If you have a big ulcer that goes 300, 400 microns deep, you have a different problem. I don't care about the endothelium under the infection. I want the eye not to rupture and calm down and have a scar in the end, and then I will send him to San Nicola, and he will do a DALC or a PK. We want to calm down the infection if it's a really deep infection. And then thickness and endothelial damage is secondary.
Все понятно?
Okay.
Окей, переводить не буду.
Just let me say that I never do PK.
Okay.
Итак, есть еще шанс задать вопросы нашим докладчикам. Если вопросов нет, то поблагодарим их за великолепные доклады. Мы вручим дипломы